October 9th. Just want to make a note that the chair is on his way. There's some traffic issue going on, so hopefully he'll be here. In the meantime, also Senator Kidani had a family emergency, and so with us today we have Senator Kurt Favela, Senator Sharon Moriwaki, we have Jarrett Keole Kalole, who stepped out for a minute, and myself, Donna Mercado Kim. And so we welcome the Department of Education. I understand Phyllis Unibasami, Deputy Superintendent, is here with us. And also from the Department of Health, Dr. Libby Char, Director, and Dr. Saren Kimball, the Deputy. And so with that, we want to welcome you today. And I'm not sure if we want to start off, Phyllis, with you. Do you have any opening remarks you want to make? And I know we sent you questions. Not sure if you got those questions and able to address them today. Are you muted? Can't hear, muted. Okay, yeah, got it.
So I'm just having a little bit technical difficulty. If you can give me a few minutes. If you want to start off with DOH and then let me get set up. I just have to switch some screens right now. Okay. I'm so sorry.
Okay.
It just went on the blank.
Dr. Char, are you able to start? Or Dr. Kimball?
Sure. So I'm just trying to pull up the questions here as well. Just some general comments since we last spoke. It's been a few weeks. So on the DOH front, we've been working very hard with the schools and other stakeholders in the learning community to have regular weekly meetings to revisit the school guidance that was released on September 17th. So after the release of that guidance, it was clear that many felt that additional stakeholder engagement was needed. And so we've made a point to identify the important questions and points for discussion. And then we've held weekly school health advisory committee meetings. And that is inclusive of representatives from DOE, including some of the principals and complex area superintendents, HAIS, and many of the private and some charter school principals, as well as AAP, American Academy of Pediatrics, American Family Practice, and others such as the school Keiki Health Nurses and the Child and Adolescent Mental Health Division. So we've had a number of stakeholders on those calls looking at those metrics and are looking at coming up with a revised draft of the thresholds. The content of the mitigation guidance for schools and how to improve safety in schools through common infection control and safety practices, that is not changing substantively, but the thresholds are talk about today. We also are looking at other appendices to that document, as I've alluded to before, where we can work out more concrete steps for the schools and how they work with us together on case notifications and contact notifications when they have a case of COVID-19 in the schools. So I'm pleased with the work. I feel at this point like we've been able to hear and discuss many feedback points and come to a point where we're close to reaching consensus on a new guidance document.
What's the timing as to when that's going to all be released, and then when the
department? As soon as possible. Yeah, we're all anxious to get something out, but I do want to make sure that what we put out is something that the group feels comfortable with and that is going to serve their needs. And so I don't want to rush it beyond that point, but we have a meeting scheduled next week. I'm hopeful that after next Wednesday's meeting, we'll have a finalized document.
Okay. I guess what I'm wondering is, what's your tentative date of getting this out versus just saying, oh, when we're ready. I think it's more important for us to have a tentative date, and you have to move that. That's fine, but
yeah. So if we succeed in getting everyone on the same page next Wednesday, then we would have it by the end of next week. If we
Okay.
don't, then we will do what we need to do to address the remaining concerns. Because, to me, I really want to make sure that everybody has something that's usable for them and not a document that's just going to sit on a shelf.
Okay, I guess the question would be for Department of Education as their timing of when they want to go back to, when they're going to start to see students and teachers safely back at school. And that would mean all of what you're working on has to be complete. So it just seems that the timetable is in limbo.
And I will say, right now, we understand that most of the schools have already decided on their learning plan for the fall based on the previously released guidance. Many of them have taken a more conservative stance than what was in the September 17th guidance, and that is fine. It has to do with what schools feel their readiness is for reopening based on the mitigation measures they can implement. So I think from that standpoint, schools have a framework that allows them to implement what they need to in the fall, but we can still get to a place where the next phase of the guidance can be applied for when they're making their next move.
Okay, is the guidance going to be aligned at all with the county tier system?
So I have distributed a document. Did you receive, there's a draft document I distributed to the committee?
Yeah. With the indicators?
So this is a work in progress, but I wanted to share this to illustrate the process we're going through with the School Health Committee and DOE as we look at the thresholds and look to realign them. So when the school guidance document came out on September 17th, September 15th was the date that CDC released their school indicators. We had been waiting a long time to see what the CDC was going to put out on schools, but given the needs of DOE to have a plan to move forward, we had to move forward without CDC when we first created our thresholds. So we made the best decisions we could with the resources we had at the time, including looking at one of the states that had come out with an early school threshold indicators plan, and that was Minnesota. And we adapted from the Minnesota guidance and felt that the Hawaii stance would be more conservative than what Minnesota had put out. So we actually had lowered many of the thresholds from what Minnesota had in terms of thresholds at when schools would reopen. That being said, when we saw the CDC guidance, obviously they chose a different rate denominator than we had chosen. They chose had a very different scheme and approach to how they looked at risk levels. One thing I noted right away is that the school guidance from CDC isn't tied to what the learning model should actually be. It simply states, here are the things that make this a high-risk situation, a higher risk, highest risk, medium risk, et cetera. But it stops short of saying, and so this is what you should do in terms of a learning model at this threshold. And they have a statement in their guidance saying this is not meant to dictate whether students can be in person or not. So from that standpoint, we went forward with the guidance we had already worked on in order to have that out there and as a planning tool for schools. As I mentioned before, though, after that, there is a lot of feedback coming back from schools. They feel the guidance we put out is not conservative enough for Hawaii. And so that's been part of the discussions that we've been in since that date.
Yeah, so I
The
guess
new thresholds that we're looking at.
But
Yeah.
yesterday, the counties had announced these tier systems, and they're all slightly different. Oahu and Kauai, I didn't see Maui or Big Islands. So how do you align what you have here so that there's consistency? So when the mayor says, oh, we're going to go from tier 1 to tier 2, and that's something that I think the committees asked for from the beginning, was a color-coded system with protocols and policies, procedures for each, and what would be the triggers that went from one to the other. So it would, if not, what we're going to...
Yeah, right. So that was the piece of...
If not, what we're
Sorry.
going to have is the county doing their own announcements on from one tier to the other, whatever triggered it based on certain criteria. DOE is going to have its own. Right now, our own state departments don't seem to have a tier system as to how they want to deal with working from home or closing certain services. So that's something that we're hoping to get much sooner so that there's consistency. So when the governor says we're now in yellow or red, everyone would know what that means as far as restaurants, airports, schools. Right now, it's still kind of different. Everyone's kind of doing it on their own. So how do you align what you created so that we can get consistency with some of the stuff the county's doing?
So again, referencing the document that I distributed, so what we like the county tiered system. I think it is a very helpful tool, and many of the stakeholders on the committee pointed out that it would be helpful to have the school indicators better aligned with the city and county guidance that's coming out and the new guidance for the counties. I have not had a chance yet to review what the other counties are proposing now and putting out, but I had a preview of some of it. It does look similar, but as you said, not exactly the same. It's going to be, if the counties go with slightly different threshold indicators for each county, it's going to be difficult to get a unified approach that aligns across everything, but I think we can still get close, assuming that no one has chosen really different indicators from each other. So that chart I've distributed is to show you how we're working with the school community to compare the different thresholds. And the two things we ended up looking at really closely this past Wednesday were, let's look at what the CDC put out, and if we were to apply it as a tiered reopening threshold, what would that look like? And that's the red, orange, yellow, blue, and green you see on the far right are where those thresholds fall. Green being in-person learning for all, blue being in-person elementary, blended secondary, yellow is blended all, orange is blended for elementary and remote, so et cetera. And then the other colored bar you'll see next to that is where it would fall if we use what Honolulu City and County had put out for their tiers, with the exception that at the highest level, the purple there, is the Learn from Home for All is inserted at where the Honolulu City and County would have hit about 200 cases per day. And that was to give that fifth tier and incorporate it in. So we're looking at possibilities of a model that combines some of the elements of CDC indicators and some of the elements of Honolulu City and County, but essentially could align with that county level indicator. Our hope is that the other counties go with indicators that are close enough that we can have transition points that are going to be similar for all of the counties. But we need to look at that in the coming week as well as we try to finalize the threshold.
Okay,
We also are hoping to simplify sorry?
But are you guys, I hear what you're saying, and I appreciate most of it. What I guess the approach I would take, other than hoping that they're gonna do something similar, is for the governor to work with the mayors and to some extent direct consistency. So they may not be exactly the same, but we have to have consistent ways of approaching this. So I'm hoping that what you created for the school indicators, what you and DOE worked on, when the mayor says we're going to go from tier 1 to tier 2, there's no question. The schools know what that means then, as if once you hopefully label this according to something similar that the mayor has, the businesses will know what that means. The public will have a better framework to work with once the mayor says we're going to go from one tier to the other, and what it would mean across the board for all these different things: University of Hawaii, DOE, churches and schools, state and county office buildings, retail. That's what seems to be missing. Is this just one piecemeal approach, going back to me with like the florists. We're not going to go one little business at a time saying you should open or not open. That's what I think is really confusing for the public, versus kind of taking this to the next level. This is the right direction, taking it to the next level so that the public knows what it means for them in its totality so that they can plan.
Yes, I think that the framework we'll propose, which will be based on likely be based on the daily average cases per 100,000, so a rate, that allows us to compare between the counties, but allows the counties to interpret that or translate that into their actual daily case count numbers, It may not match exactly, but it gives a framework to line up with that, roughly speaking. So I think it does reach that intended consequence of just having all the counties kind of having the same playbook. And not just for the counties, but the schools too. We remind everyone that it's also how they choose to implement that guidance in a way that makes sense for their classroom, for their school. So there's always going to be slight differences from, if these thresholds are not meant to be absolute, but they will provide that common framework to think about how to transition from each learning model to the next.
No,
I
so-
do think
but-
that where we're headed is to have that statewide model.
But if the mayor says we're gonna go from tier 1 to tier 2, right? In this situation, we're still waiting for the superintendent then to say what it means. Versus when the mayor says it, it means that for everybody. I don't think that that's good, that we're gonna have to wait for all the different stakeholders in charge of different sections of government to move
Yep.
independently. If the metrics is gonna be agreed to, once the decision is made, it means that for schools, it means that for restaurants, hotels, it means that for government buildings, government services, public transportation, everyone knows what it means to move from one tier to the other. And only one person makes that decision, I guess, as determined by the governor right now, the mayors.
I appreciate the desire for the clear thresholds, but within the school setting, and this is part of why the school guidance is separate, it also depends very much on how that school can implement social distancing in their classrooms, the things that are needed to have any kind of blended or in-person learning model. So it's not that we are waiting for the superintendents to interpret the guidance, but rather that when they hit that threshold, they have to decide how they're going to implement that in their classroom. And this is a two-part guidance. The thresholds provide one framework for transition, but the other piece of it is what can you do in your classroom for mitigation. And that's probably even the most important part of the guidance, which has not changed in substance, is these are the things you can do in your classroom to allow safe learning in the classroom.
So the question is, okay, now we went through all of that, and we've been bringing this up. We've been bringing this up from pretty much what Senator De La Cruz is saying. So the question is, the Department of Health is going to adopt the CDC metrics, or we're going to go and reopen back on Monday with distance learning, and go on to with what you guys had made before the CDC's printout.
The choice of the threshold framework is still under discussion, but the leaning of the group has been to align with a metric that would be similar to the county metrics and hopefully to a statewide
Yeah,
metric
because the reason why I'm saying this, okay, this is
rather than the CDC metric.
okay. So who runs the school? The city or the state? Who runs the schools? Who runs the schools? This is the problem. We're having a city and county that do parks and rec, try to dictate what's going to happen in my community's classrooms. That shouldn't be happening. We should have taken the lead either from the governor or the superintendent and say, hey, schools, this is my policy where we're going to come up collaboratively, not blame every single principal, say that each school will cut and paste. Reason why I'm saying this, because right now, I'm getting calls from my school, James Campbell High School, that they're not following none of that. None of that. None of what you guys are saying. None of that. Campbell High School is not. They're not in compliance. Numerous and numerous of complaints and emails from the teachers in my district. Because why? Because you're leaving it up to a principal. He's not a Department of Health. He's not a health expert. He's not a doctor. But you guys are letting these guys dictate in every school differently. Cannot. We have to, just like how we have regular laws. Okay? You speeding at 25 miles an hour, I'm going 26 miles an hour, but the school zone is 20 miles an hour. Are we both breaking the law? Yes, we are. We're breaking the law. No matter how much speed it is, we're breaking the law. So why can't we have a unified state? Yeah? Say that all the schools in the state of Hawaii is going to do this. Not each county dictating what our state schools are going to do. They're not running our schools. Is the city funding?
So let me be
No, but that's what you're saying. You're saying it's depending on,
Let me
you
be
like the way the
clear.
city is going though. You know what I mean? So why can't we have the superintendent or the governor and the Department of Health is all state, make their guidelines and tell the city, this is what we're going to do at the schools, and this is what we're going to come up with. Why wait so every single county mayor making up their own piecemeal and dictating what the state should do? That's the part I don't understand. I'm getting numbers of emails. It's just frustrating. Okay, go ahead. Go ahead.
Oh, no, I think perhaps, I hope I am not being misunderstood. The guidance is statewide. So the school guidance is statewide. We're not making different guidance for each county.
No, but each
All I
school
say
does their
in
own.
the hopefully statement is that the counties would align with what the state is putting forward. But this is statewide guidance. The thresholds that come out will be applied statewide. It's not going to be different for each county.
So every neighbor island school, every school in the state of Hawaii right now is independently doing. They don't have an over guidelines. Each school is doing their own thing. Remember Sesame Street, which are these people doing their own thing. That's what's happening. And that's the reason why the teachers are scared, parents are scared, students are scared, because you're making principals dictate what's happening in the schools, which they don't want to do. They don't want to do it because if something happened, it's not going to fall on the superintendent, it's going to fall on the principal. She's making them the scapegoat. She should be the leader and lead this, and this is what every school going to do. And then if you got them tweak it a little bit, it's fine. But don't let every single school do their own dictating and saying what they're going to do to her, and then she approve them, and then later on something happened. Hey,
So-
I never come up with them.
So they're still in the process of amending it though. So it's not final. That's what I'm asking. When is it going to be final? She's saying that she doesn't know when. So I was hoping that we could get a date, at least from the DOE. What's their target date
Yep.
to kind of have something so that it might address some of your concerns.
Because Monday they're going back already. Some of these guys are
Yeah,
ready.
so we can ask, when Felix comes on, we can ask
Okay.
how does that Monday align with what
All
this
right.
process and how it's going.
Just taking this too long. People is getting sick
Dr.
and dying.
Campbell, I appreciate the department coming up finally with some metrics for the different tiers to know what we're looking at. Because I think because this is a public health issue, we all look to the Department of Health. So what I'm asking from the Department of Health is to align the counties by the metric, and within the metric, these are the activities on congregating, on whatever the different activities are within that tier, so that whether it's a school or a hospital or a gym or whatever, they know how to open, and when they open, what are the standards they should follow. If they had that, each county might be at different level, different tiers, but if they move to the yellow tier, they all should be following this. The schools, the hospitals, the gyms, everybody should know what the protocols are. I think that's the kind of guidance Department of Health could give that would make it more consistent across the board, regardless of whether you're in a county or a school. You know what to expect and what to do, and maybe the Department of Health as a consultant to answer questions as we start to adjust so that we all are on the same page. I think right now there's too many moving parts and people are, getting upset. So if you could
Thank you.
look at that.
Yeah, that is the second part of the guidance, as I said. The thresholds are just one part of the framework, but the second part is all about how do you set up your classrooms, what decisions do you make on your campus to make it as safe as possible for reopening. And it's layered guidance, right? It's many things together. It's the universal masking, it's the hand hygiene, it's the cleaning practices, et cetera. And that's all in part 2 of the guidance. And so that has not changed substantively, and that is what the September 17th, I think the most important part of what was released on September 17th is those specifics of how do schools look at what they have in place in terms of their readiness for reopening.
So and those are
I
consistent.
also think that there will be additional questions that come up inevitably. That is that is our role, is to be a resource for schools as they navigate that, and they may have questions about what's in there. We are available as a resource to the schools to answer those questions.
And when those questions come up, it would be nice to have, I don't know, on your website or on the DOE website, FAQs, so that you start to get people aligned, because everybody's doing their own, and with the state as well in different sectors. It would be nice to have that where you can go to find out, what do I do? The people want to follow the rules, but they have none to follow consistently. So that would
That's
be
an
helpful.
excellent suggestion. We will definitely take that into consideration.
Question. Okay, why don't we go back to, before we just focus
you.
only on DOH, why don't we go back to DOE and have Phyllis make some opening remarks? Or you have a question?
This is not quite DOE. Can I ask this quick
Oh,
question?
go ahead.
I just wanted to follow up, and maybe you're not the right person, but I want to know what the status of the community partners, because in some ways it affects the schools, because many of the children that go to the schools, especially in my district, are from Pacific Island nations, and there's a communication problem with the families, and until we have these community partners working in the community with the families, it's going to affect the schools as well. So if you can give us an update, I've been talking about these community partners since June. They keep telling us, DOH keeps saying, yes, we have agreements, yes, we have handshakes, yes, we have this. And when I go to the community partners, they go, not yet. So it's crazy. I mean, this is October, and they say, you guys still don't have an agreement unless something happened in the last couple of days.
By community partners, do you mean the clinical providers?
Like Kuli Valley, like the Waianae Comprehensive
okay.
Coast, you know, those different
Yeah.
community partners, which we were told by some of the epidemiologists that there's so many cases that it's hard to contact tracing until you have these community partners in place. And we've been, talking about this for months now.
So engagement with the federally qualified health centers is really the crux of the next phase of how we expand out, scale up contact tracing. And it's active, it's being worked on. We've had conversations with Dr. Hirokawa from the F2HDs about how to best get the data transmitted. And so a lot of this is also about data flow and workflows. We already do receive case investigation reports, case reports from the providers. And so we're looking for better ways to get that information, because I think, as it's been stated on the news and other sources before, a lot of that has been coming in through fax reports. We'd really like to get a streamlined electronic system so that data can flow easily from the F2HCs to us. So that's what's being worked on. The infrastructure development for that kind of data transfer does take some time. We definitely feel the urgency, and we want it to go as quickly as possible. But we also need to be able to get that up and working so the data is coming through reliably.
Okay, I'm sorry if I sound frustrated, but data is one thing, but talking to the families, interacting with the families, having these counselors, these nurses talk to the families and go to the families and make sure they understand what's going on, that's separate and aside from the data. Yes, you need the data, but we need these boots on the ground, knocking doors, talking to these families, following up with them by people who can speak their language. And so for you to say that you're still in the process, when Dr. Park told us a month ago that they had handshake agreements, which they didn't, told us even months before that they were working with them. And when we came to visit the DOH on our site visit, we were told, yes, we have these agreements. So I'm very frustrated about this not happening, and why handshakes, which they didn't have. But what is so hard to get these people who are ready to go out into the community and have some kind of agreement with them?
So I think there's a couple different pieces to that answer. On the DocD side, it's mostly about how we more effectively streamline our triage processes between what the providers, what their interactions are with their cases and their contacts, and how we communicate about that. But there's also the outreach part that you're discussing, and that's, I don't know if Dr. Char might have more information on that. I know there's been discussions also about community health workers and engagement on those fronts with the federally qualified health centers. I mean, that's not being directly handled by DocD.
Okay, I would like to get an update today, if possible, on what is going on, because this is taking way too long. I mean, it shouldn't take a rocket scientist to figure this out and get it going, especially when we have been told directly that it was done or that was already being done. And as of the couple days ago, I was told, no, there's no agreement yet. There's nothing signed. The city is working on something, and the state supposedly is working on something. So again, the coordination there is of concern. So we really need to get this worked out if we hope, with the opening of our state on October 15th, more visitors coming in, people coming in from international, and it's going to be a mess, and it's going to affect our schools as well. Chair, I'm sorry if I.
Okay, you said that that's part of your next phase?
Yeah, what phase?
So we've been working to streamline, on the contact tracing side, we've been working to streamline our internal procedures first, and that was most important because we need to have a solid foundation. Now that that is largely in place, we're now working to figure out how we also scale that model out to our healthcare partners, and what pieces are they already doing that we can take advantage of, and just through better flow of data and workflow, what pieces are they already shouldering that we can be capitalizing on, and what things do we need to still work out, where do we still have gaps, and where do we bring the resources to bear to make that happen. So that's what I mean by saying phase 2, and that is actively underway. But I think it's different from the question that Representative Mercado Kim raised, because it's this is not a contractual arrangement. This is part of the disease reporting process. But you may be referring to other agreements that are more around the support services.
No, so Senator Kim had brought up a while ago that we need MOAs with all the different community health centers, so that when they get patients, what's going to be the protocols and procedures, so that when they start to interact with Department of Health on both the testing, the contact tracing, the guidance, it should all be consistent, and the community providers tend to have a better relationship with those who are going to be infected. I mean, I just saw on the news last night, a lot of the contact tracers aren't getting phone calls back because people are afraid, they don't want to talk to them. The community partners would be able to hopefully mitigate some of those issues, but right now they're not taking a formal role in what needs to occur.
Right, so I think those processes need to be more clearly defined, and that's the phase that we're working on.
Okay, so what's your timeline on that? Because she has brought this up since June, and it has been told to us that it was in the works. It would actually, as she mentioned, it initially was told to us that we do have agreements. Then they said, oh, well, sorry, maybe we have some verbal agreements. And so it's a little...
And this is where I'm confused, because I'm not sure that agreements are necessary for the work that we do for case investigation on the DOC side. So I'm not sure what agreements are being referred to, other than perhaps there are agreements in place for some of the support and wraparound. And that's where I'm looking for whether there's other information.
Okay, clearly there's a disconnect here, because clearly Dr. Daroff from Kokua-Kalihi Valley have been in contact with me. I have many emails back and forth. He's told me directly, he's been in contact with DOH, that you folks were hiring a specialist to do the MOAs, that they're waiting on these agreements. So for you to now say that you don't know about agreements, I mean, this is clearly a disconnect. So
the question was raised to me about an MOA, but what we're asking the F2HCs to do is really just an updated case reporting form. So they're already obligated under administrative rules to report cases to us. So I had questioned why we were going down an MOA path when this is actually
because the community
case reporting function.
Because the community
I'm
sorry, the community partners need to know the guidelines. What is expected of them? What are they supposed to be doing? How do they? So they wanted some kind of agreement. Now, whether it's a formal MOA or an informal agreement, I don't care what it is, but there needs to be understanding between the partners so they can get out into the community and start to work on this. At this point, they're waiting, and they've been waiting for months. So there's no excuse. I don't understand what it takes so long to sit down with them and get an agreement. They were told that you guys are hiring a specialist, some special person to draft this MOA, and that was a month ago. So I'm sorry, it's just frustrating. In the meantime, people are dying, people are getting sick, and we can't get the kids back into the schools. This is just.
This was said a long time. They were sitting here and jokingly they said, oh, we give a handshake. That's all we needed, right? And after that, when she keep asking, oh, we got to give an MOA, all this kind of other stuff. The bottom line, I don't think you understand the importance of the community outreach. Like how Senator De La Cruz has said, the phones start calling because why? They don't trust. They don't trust. So the only way you want to trust is you get the community people involved and let them work with you guys side by side in the community so they can get these things going forward. But you thinking that
she raised her hand.
Dr. Char.
Oh, wait, yeah. Go ahead, Dr. Char. Go ahead,
You're muted.
Dr. Char.
Oh, sorry. How about now?
Yeah, go ahead.
All right. I talked to David DeRalph at least a few times a week. I spoke to him yesterday, and I think some of the confusion, and that's what I'm trying to help him sort out as well. Initially, the agreement was that he helped do contact tracing because exactly as you say, the guys at KKV know the language, they know the people, they know the families, so it makes sense that they participate in contact tracing. It's their community, it's their patients anyway. So just to let you know, they actually are doing that. They're taking care of their patients. I think as far as David and I can figure, the confusion is whether, so for that, they don't need an MOA, it's their patients. The confusion arises in, is the expectation that they do more beyond just their patient, that they also help others in the community that are related to that case, that may be contacts from that case. And that probably would need some sort of agreement for us to be able to share that sort of data with them. And so I understand the frustration. I'm quite frustrated too. We're trying to sort it out. I think there's been misunderstandings. As far as the city piece, the city is contracting with the FQHCs to provide some funding for them. So that's a separate issue. But with the Department of Health, I assure you, I am trying to sort this out with David and get things rolling so that we can get moving on it. But in the meantime, just so that you know, they are doing the contact tracing on their patients. They are following up, and exactly for the reasons that you know, it's really important that they deal with their patients in their community. There's trust there. They can get information that somebody else might have a really hard time getting.
Okay, so you're talking about, so really what we need an agreement for are those that are not currently covered because they're in the community, but they're not direct patients of the community center.
Exactly.
So for instance, in Senator Kim's case, she had a housing project in her district. Not some of those cases may have been patients and some may not have been, but we need help in that case because it's in the community.
I agree.
Okay.
So what's the timeline, Dr. Char? I mean,
I will take it up with my staff again. I'm sorry, I don't know enough about how the contract process goes yet. I know how long it'll take.
Well, can we get some kind of
frustration?
Yeah.
I'm also frustrated. We will work on it.
Okay. We need deadlines, because if we don't have deadlines to know we got to get it done by a certain time, because this has gone on too long and it's just frustrating for everybody involved. So we're looking to you for that leadership and to get it done. Thank you.
Okay, so why don't we veer off a little bit, just a little bit, and go back to Phyllis, since she's now online.
Aloha, everyone. Thank you for having me. So let me just start off very quickly that we are right now in fall break of the public schools. And I do want to express appreciation for Dr. Kimball's and the team's work in working with the plethora of schools, private, charter, and public schools, in coming up with the guidance that and the conversation I can tell you that from being a participant in that conversation with the Department of Education being represented by myself, Heidi Armstrong, Jennifer Ryan, who used to work for Department of Health, now works with us, 2 principals and 2 teachers, that we acknowledge the differences between private and charter and public schools and in the way that they're run and the decisions that are being made, how decisions are made and the decisions being made. So for us, since, and I can only speak to public schools, so please keep that in mind, is that since the beginning in March, we have been using the governor's transition document that starts with stay at home and goes all the way to the new normal. And we have not deviated from that as the phases in which we are looking at what is happening in the state and what are the ways that we are going to use that information in the Department of Education. More recently, and just fast forwarding, I don't want to go into every single step that we've taken, is that when the Department of Health came out with their guidance, we used that to take a look at what are the ways in which we needed to mitigate our strategies to make sure that we were doing what we could to keep our schools safe in order for our students and our employees to be at school. As Dr. Kimball explained, is that the DOH guidance came out right before the CDC guidance, but we have always used, until we finish up this conversation, we have lined up the DOH and the CDC guidance together to make sure that we weren't missing looking at the data through the lens of both guidance. And so as we've been having this conversation, and Dr. Kimball did put up that slide, that meeting slide with the bell curves on it, I want to tell you that we have, the conversations we've been having and sharing with the leadership has been that this is probably one of the most helpful slides that we have in which we are able to capture data that is happening in our state and look at it through the lens of what is happening on each of the islands, because that matters, and then what is, and how it compares to the CDC guidance. So if you take a look at the thermometer on the side, and I have my own little graph here, the red signals for us the stay at home and full distance learning. And then when it moves to the orange, the yellow, the blue, and the green is where we want to get to one day, hopefully, is when we're returning everyone back to school, all of our students and so forth. The orange and the yellow and the blue is where we are having the conversations about what makes sense. And so this chart that Dr. Kimball put in front of you is very important to the department, because while we have stipulated in our core assumptions that while we are in orange and while we are in yellow, that we would do distance learning, we also talk about how do we start to bring students back, starting with our most vulnerable, our special ed students who need us, need face-to-face, whether it's medically fragile, students who just will not learn through technology, our EL students, and our students who we know have difficulty learning for whatever reason, whether it's home life and or home situation, and the school creates a protective environment for those students. What we also know is that we don't want to just use a trigger or a graph like this to make all of our decisions for us, because we know that where we serve in the community absolutely matters. And so what we've done is that in our core assumptions document, that all transitions, while the colors gives us an idea of the risks that are seen at the community level, we also know that we have to take a look at how and as senators, you know, and visiting your schools, that you can go to one school and go to another school and you'll see a very different set of facilities. And so the facilities absolutely matters, and the ability of the school to do the social distancing that is expected in all of the documents coming from the medical profession. And so when we talk about transition from where we are right now, which is distance learning, and with some of our most vulnerable students coming back to school, what we also know is that we have to evaluate the operations, the workforce, the level of the threshold for workforce, and the facilities, and how can the facilities accommodate, and how will the school be able to do social distancing as we increase numbers of people on campus. While I know that people would like one metric that everybody can easily understand, the reality is that every school is a unique community, and so what we try to do is create criteria that the schools will apply to make decisions, and that's what's held constant, and that the decision and the outcome of using that criteria has to then be looked at uniquely for the conditions and the situations of the school. And I think that I want to throw in one more piece that we've been talking about, is that while we have been doing the mitigating strategies, the 5 that are in the CDC guidelines, and we have been trying to show over and over again that how are we making sure that there's ample supplies at the school, and we've set a target of 60 days supplies. Know that it is a challenge. It has been a challenge in the past to get the supplies on time to our, especially remote areas on the neighbor island. We've now developed a agreement with Hawai'i that they will drop ship those supplies at the school door. Before it was shipped in bulk in one place, and then we had to go out and distribute, which caused delay. We also are looking at the different ways in which the mitigation strategies are being implemented, and recently at the board meeting stipulated that that the way that we were going to look at and make sure that there is monitoring and compliance with the mitigation strategy is that we needed to have a cycle that all staff and students would be trained, and this was on Thursday, that there would be a cycle of review and reminders while school is in session. So for instance, monthly reminders, written communication, that there's a system for monitoring and reporting compliance for the mitigation strategies, and there's articulated corrective action measures for non-compliance with the mitigation strategies that are listed in the CDC document. I also want to point out, as someone who's been working with the principals and the complex area superintendents, is that when you look at the chart that Dr. Kimball put in front of you, it is really important. While people have talked about 714 and so forth, for me, and in talking with others, is as you look at that chart, and let's just take Oahu, because we're on this island and very familiar with it right now, is that if you only look at the 7 days, it looks like it's in the orange, and we should be able to, quote, just do the blended learning, and what that means, right? Everybody has an idea about. But when you go back 14 days and you look at it, it still sort of signals, yeah, you know what, we could do what we're doing and maybe even do more. But when you go back 28 days and you look at that piece from the 28 days back, what you can start to notice is that we used to be in the red, right? So now as we're making decisions in our schools, the question is, how much of our community contributed to that what that color that we're in right now. And that's the discussion that we're trying to have. We're trying to figure out how to get the data in such a form that people understand the decisions that the principals are making. And I know that there's concerns about, is the principal ready and able to make that decision? And what I want to say to you is that they are situated in such a place in which they know their staff, they know their kids, they know their community, and they are not alone in making the decision, but we've got to be able to give them tools like this that help them to tell the story through the data to justify the decisions that they're making. And in some of our schools, the data and the knowledge about what is happening in their community will tell them that we need to hunker down a little bit more, whereas other schools may be saying, you know what, my students need us to open up our doors a little bit more, because right now they're struggling and they need our help. And we want them to have that ability to make that call, and we will support them in it. The criteria and the strategies are universal. I have that agreement across the complex areas. However, the needs of our students and the will of the community is going to be different as we look at our neighborhoods and the schools specifically.
So Phyllis, the indicators sheet, that's already distributed to all the schools? This is a draft?
The one with the bell curve? I can't see from where I am.
It's core indicators, and then there's lowest risk of transmission, lower risk, moderate risk, higher risk, and then highest risk. It's the color-coded.
I think he's talking about the CDC indicators.
Yeah.
Is that the slide?
Yeah, is that already distributed across the department?
That, the indicators has been distributed. I'm sorry, Senator, I don't know I can't see from the distance what paper you're holding up, but I will tell you that we distributed not only the DOH, but the CDC indicators, and that has been distributed.
Okay.
So I guess that's the confusion.
We are using the CDC indicators. We want to always have the county, the CDC and the DOH guidance side by side, because we need to see what everyone's saying. We cannot be myopic and just look at one thing. And what we do is we look at the whole thing. But I'm going to tell you that for the most part, we are looking at the CDC guidance, because when we look at the 200, where the red ends, right? It's at 200, and when you sort of step back and you go, as people in the community, what would our communities tolerate? It really does mean a lower threshold.
Yeah. So, which do the schools use? The CDC one or the memo dated October 1st from Catherine Payne?
October 1st from October 1st.
The board.
Okay. So yes. So just note that when the board met on October 1st, we were advocating for the CDC to be the. While in her memo she says to look at the DOH guidance, there were questions in the memo. Hold on.
Duncan, do you have the DOH one?
Page. You have the memo.
Is this one too?
I might, but this one
Page
is not
12.
This is the one that's
the best one so
CDC,
far.
this is the CDC.
Page 16, where she asks that there was a request that we also take a look at the CDC indicators and provide a rationale on how to determine the learning model parameters. And in our conversation this week with the committee that included all of the different representatives from the private charter and public schools, we agreed that the CDC guideline for the upper threshold made a lot of sense, and then we were still in discussion about the lower thresholds.
Okay, because what I'm just trying to figure out is at what point are you gonna um, consolidate some of this? Because to me, the CDC guidelines seem a lot clearer. You know, they give you the indicators. I'm not sure if the core indicators and the secondary indicators at times could be in conflict or just have different numbers, because one is based on actual case numbers, and the secondary case indicators are based on percentages.
So we have been using, and I will tell you honestly that we have been looking at the CDC indicators as a starting point because we believe that that is what we hear more often as being supported. And as we've talked with DOH, it has been helpful for us to take a look at what our local context is telling us about how to interpret those indicators that are being used nationally. And that's me coming from an educator point of view, listening to the conversation with DOH and with other institutions.
Yeah, so what I'm trying to figure out is how can we align this to the county tiers though? Because in that way, when the mayor says we're going to go from tier 1 to tier 2, which I'm not sure what that means for the CDC indicators, where you would go from dark green to light green.
So, and I'm not speaking for DOH. I'm going to just talk for the DOE school, right? So when you take a look at what Dr. Kimball presented to you, when you look at the red, it's clear. It's distance learning. Hardly anybody should be in school except maybe the essential workers and some of the people that need to be on campus. And as we move to orange, yellow, blue, and green, what we should be doing, and think of it as like if this is a temperature bar, what we're doing is dropping, right? So we don't go like flash cut to, okay, now everybody's back in school when it turns green, right? We actually, what this chart tells us is to be patient and watch the trends, right? So what we're doing and talking about in the department is, so if for a period of time, we're seeing prolonged holding of, this is what's happening in our community.
No, but that's the same thing the mayor is using on his tier 1 to tier 2.
Yeah.
I mean, it's very similar. So I guess the point that I'm trying to make is that when a principal or a complex superintendent hears the mayor say we go from tier 1 to tier 2, there could be confusion if the DOE is still stuck at a certain color when the county has now moved on to a separate tier.
I see what you're saying.
So it should be moving all together, because it sounds like you guys are all using the same indicators.
Right, but we're not all in the same location.
No,
right?
but you leave it by county. So if every county already has so far Kauai and Oahu has announced the tier system. So that way, as a teacher or a principal, you hear, oh, the mayor is going from tier 1 to tier 2, you know already what you got to do in your classroom.
So I wish it was that automatic, and I'm going to tell you that it's not. And here's why: is that if you talk to your principals, what you're going to find out is that there also is what I call the community will. And that's the only way I know how to explain it, is that there are many parents who are saying, I'm not sure I am ready to send my child back to school until I see blank, right? So for some of them, it's like not for the rest of the year. Some of them are gonna say, not until I see the numbers for COVID drop completely or to a certain percentage, right? And so what we have been doing in the department is saying, okay, given that our school model is this, and then how do we support families that want something else? Can we do it? So when we talk about whether or not we're keeping the school open or closed, some of that also has to take into account our employee, our ability to operate the school safely. So do we have enough employees can we keep using our facilities? Can we keep social distancing? And what are we seeing in our families choosing in terms of what they're seeing in the public, what they're seeing in terms of community spread, and what they are communicating to our principals?
Okay, I still think that there's some confusion, but
I have a question for.
And Senator, sorry, and you know what, Senator De La Cruz, I totally agree. There is confusion. I think people are including our leaders are trying to make sense out of a very challenging time.
yeah, because I'm just saying that at the same time, some of the principals are saying, well, I'm not in a position to know, because I'm not a medical professional, when to go from one tier or the other. That's why I'm saying, if you tie it to the mayor or Department of Health based on the health guidance, and as they switch, at least the principals are now deferring to a higher authority, versus them having to make it, and them what we're getting from, I guess some of the emails is like, hey, I'm not in a position to make these decisions.
Right, correct. And that's why this chart that is in front of us right now, the principals have not seen this yet, because it just came out yesterday. But just know that is, to me, I'm asking that this is actually the answer. How we display the data so that the principals can understand where are we right now in the state and in their community.
Okay, you know what, can you email the committee clerk, or if maybe one of your staff, who's hopefully listening, if they can send over the health guidance, because all we have are the CDC indicators. So we're unable to do a side-by-side comparison right now. We have the memo from Catherine Payne on October 1st, and then we do have what Kim, the 7-day cumulative cases graph.
Yeah, that's the graph. That's the one that Dr. Unibasami is referring to, the 7-day cases graph.
I'm not a doctor.
Go ahead.
I have a question for Dr. Kemble.
Yeah.
What was your role in the development of the City and County of Honolulu's tiered reopening strategy?
Yeah, I was invited to many of the discussions to help develop that reopening strategy. So, and it has been discussed with the governor as well. So there was a lot of collaboration that went into that discussion. One point I just wanted to make, in addition to what Phyllis has been saying, is that that is the goal, is to look at what CDC has, to look at, we sort of discarded where we came from, because I think we came to consensus quickly that it's not serving our needs. So we needed to move to a new version. And then we looked at what city and county had developed, because that really incorporated many things, and not just what data was available nationally or from other jurisdictions, but really looking sector by sector at our realities locally and what made sense for those. And I think we need to do the same thing with the schools. So that is the week-by-week process we've been going through. I know we all feel the urgency to have a plan in place, but again, I think until we have a plan that all of those on the committee to begin with can understand and feel comfortable with, we have to also bring that to the principals and have them be able to understand and feel comfortable with the plan. So we need to start from that solid footing of a plan that everyone has grappled with, has understood, and now we can talk about how each individual school implements that. So our goal is to end up with one metric, not multiple metrics. And that's the process we're going through right now. It is a long and painful process in some ways, but also really, I think it has been rewarding in the sense that we now have a true dialogue going with the schools, and we can hear what the concerns are. How does that affect how we look at this zone or tier here? And where do we need to make some changes to make this plan right for Hawaii? So for instance, just to give an example, the CDC guidance would have a change in learning threshold for 1 case daily on Hawaii. And that's, is that really, we had to ask ourselves, does that really make sense? And it's because CDC guidance is designed for much larger jurisdictions on the whole. So when we break it down to a small county level, it might not be the thing that makes the most sense for that county. And so those are some of the kinds of things we're looking at in detail with the schools to say, okay, I think we can get to a place that is really kind of gravitating to what we did, the work we did with the city and county of Honolulu, and that the other counties are working on now. And we can get to a place that's convergent for the state. And that's really where we're headed, and that's the product we want to be able to put out by the end of next week, if we can get there.
Yeah, but schools open on Monday.
And in the interim, they've made plans that I think we've all looked at are appropriate. For the most part, they're more conservative. So what it does is it means that there are fewer schools that are feeling comfortable with opening in person. But there is a plan in place. And so in that regard, I think it's most important that the next step we make is the step we make together, and that we do it properly. So I don't want to rush that process to the point where we put out another plan that nobody's going to look at. Because in all candor, what I hear Phyllis saying is the schools aren't really using the plan we put out before. That means it's not a good plan, right? So we have to come up with a good plan that's going to be worthwhile for the schools.
So if, let's just say a school principal have a case on campus, what is the timeline and the protocol for the Department of Health and the DOE to react to this case? That's what they like know, because in the previous past, the reaction was very slow to none. So we like know what is the protocol, the actual protocol. If a principal get notice that a student or teacher or person working on campus has the virus, what is the steps that they need to take?
Let me start, since most of the time those cases are initiated within the department. And so in most cases, the principal will either get a notice or be told that someone is not feeling well. So it's either when we get the notice, it's either a confirmed case, my apologies, or it's a potential case, right? There's a possibility that this person may have COVID or have been in close contact with someone who has COVID. And so in those cases, the principal is we already have in place they have all of our cell numbers, the COVID response team for the Department of Education, which includes myself, the liaison to the Department of Health. We have someone from facilities who takes care of all of the cleaning protocols when we need to bring in somebody professional to do the cleaning. We have Cindy Covell, who handles all the personnel issues. So what kind of leave and so forth that we might need access to. And then Lindsay Chambers, who is our communications officer. And when the principal is first notified that there is a potential case on campus, he or she is setting off this group text. They have all of our cell numbers, including their CAS, and they send it off. And so within about 10 minutes, we're probably getting notified. Within an hour, if not less, the principal is being contacted because we are trying to get the information around who, date of birth, the things that a school level person would know that will help DOH to enter into this case. We need the name, we need contact information, and we're passing that off to DOH within the hour. As we get more information, we're passing that on. And so DOH is getting that information as soon as we have that available.
So you guys go to the school?
I'm sorry?
You guys go to the school. So like say right now today, I call you up, I tell you my school
We don't.
custodian have. So then how does this custodian or the principal get this person tested?
So they are usually the person, okay, so if it's a confirmed case, they've already been tested. And what we're asking for is the documentation for our records, because now we're talking about leaves and so forth. But if this person is a potential contact or has might have COVID or is worried about it, then we are asking them to go see their primary care or to go to one of the testing stations and get tested. But we release them from work at that point. When we do show up at the school is when the principal asks us for professional cleaning of a part of the campus in which that person has entered into. And when this is a new decision that we just made. We've had break-ins in our schools, and what we realized is that we have no idea who broke into it, and so we just revised some of our procedures and said that when there is a break-in into any part of our facilities, that we will do professional cleaning. So that is another time when we are showing up to do the cleaning.
See, this is the thing that I'm trying to explain. So the principal has this responsibility to notify you guys in the Department of Health. Now, I'm the person that has the virus. Now you're gonna have me go out into the public, into wherever I'm gonna go and go get tested, and maybe possible everybody that I had contact with. But these guys are already afraid of staying home and not working. That goes with the principals, the custodians, cafeteria workers. So even if they're possible might be infected, and if the principal say, hey, you might be infected, Senator Donovan De La Cruz, go get tested. He don't go get tested. So what I'm trying to explain to you, if you guys don't go to the source, like how you guys didn't go to the store, not you, the department have to go to the source at the school, then he gonna take a while before he gonna get his testing, because he don't want to go and find out that he's not. Is he immediately going to be out of work? Is he immediately going to have to go take a vacation or sick leave? Those are the things right now they're worried about. The custodians and all the guys who's there. Now there might be a possibility that I got sick at my school. Now I got to take these precautions. But what I'm saying is that instead of we having them go to their primary care and they're going to tell this person, that person. The Department of Health don't have a task, or don't put a task force for the DOE. That's the reason why right now we have a problem. DOE, within an hour, this person will call that person, that person will call that person, that person will call that person. 75 other guys got sick already within an hour. I mean, that's the thing. Are you quarantined? I mean, that's what I want to know. What is the walkthrough? I'm sick. Are you going to put me in a room until I can get tested, or are you going to just send me home?
Okay, so to follow up, Senator, is that when there's a difference between someone who is positive, if they are positive and they're not on campus, we do not ask them to come back on campus. If they are positive and they find out while they're at school for any reason, they are immediately sent home. We do not ask them to go anywhere else, and they are then placed in isolation. And that's my understanding of the terminology. When we are worried about that they might be a close contact, in an abundance of caution, we ask them to get tested, whether it's a doctor or they go to a testing site. And they also, we also put them also on telework so that they are not, if they are a potential spreader, not spreading anywhere in the school. So I do believe that our procedures are very clear, and we work with, and the reason we get on the phone right away with the principal is to help the principal clearly think through who needs to be released to go home and get tested. And I do believe that if you have any kind of doubt about this, that I can give you, I can bring in principals who have gone through this, have had real experiences, and they can walk you through the protocols that they experienced, and be able to share with you whether or not they found those protocols to be sufficient in keeping their school facilities safe.
So the protocols was put in before or after the case at Dole?
The protocols were already in place. And I cannot talk about the Dole case.
I'm not asking you, I just asked you, was it put in
Yes.
before or after? Because this is the thing, we don't like say this, we don't like say that, but then people are getting sick and dying because we gotta stay behind an iron curtain. I'm not telling you to give names. Hey, Dole was infected, let everybody know in the area. Oh, we cannot do that, we cannot do that. Why? You know, that's the kind of stuff. If a Campbell High School gets somebody there, I definitely want to know. I want the news to tell me, I want the principal to tell me, so at least people in the area know that possible somebody at Campbell or Ilima was possibly sick. But we're going to hide them, and then we find out in the news, somebody leaked it to the news, and then we find out through the news that somebody from Dole got sick and died. Those are the things that we do not want to know. We don't want to know it. It's too late already. You know, it's too late when that kind of stuff happens. But it's okay. You guys have your guys' policies and your guys' rules. So, again, thank you. Appreciate it.
Phyllis, I had a question about the testing. Are school health rooms going to be able to provide tests?
So we are in the process, oh gosh, okay, I'm not really good with my calendar, but I think it was last week, had a discussion with Hawai'i and the potential of bringing in more testing kits. And so really was being briefed at that point in time about what the test looks like, what it constitutes, and who can actually administer the test. And is it self-administered and up to what age, or does it have to be done by a professional, etc. We had that discussion. I'm not sure what's going to happen next, but we did talk about under what conditions that the testing could be available in the schools. We've also had conversations with Heidi Armstrong, our assistant superintendent, that covers school health, and taking a look at who in the Department of Education can help administer the test. And we're looking at potentially our contract with skilled nurses. And so this is all in the works right now. And so as Hawai'i gives us more information, then we're going to be able to, we're actually getting ready to see if we can do this.
Okay. Who determines, or how are you determining which schools get tests?
I'm actually thinking that they're going to help us to, because I think I'm sorry, I don't have my notes in front of me, but there's only a finite amount of tests that we will probably get our hands on. And so then the question becomes, how do they want us to prioritize those tests? And then we would then determine where to place those tests.
Okay. And then who?
Sorry, and I think because it has a shelf life, that was the other thing that I asked about, was there's a shelf life to this test, and so making sure that we're not stockpiling in a place where that test might not ever get used, and placing it somewhere where it might be a hotspot in our community, and making sure that we're prioritizing towards that area or that locale.
Okay, so and who would be determining, or who is eligible to take the test? Going back to the previous conversation with Senator Favela.
Mm-hmm. So my understanding is, I'm not sure.
Maybe I can speak to this a little bit. There have been a series of testing strategy conversations for the state, and schools are a high priority as those discussions are underway. There are many discussions going around procurement to understand what is going to be procurable. And so I think some of the decisions about how to deploy those tests in the schools are going to be based on what we're able to procure. But we're going to need to have like a plan A, a plan B, a plan C, depending on what comes through in those processes. And it's not just about having the dollars to procure, it's about a supply chain. So some things that we've put in for procurement and I'm just speaking, I think Kathy may be the best to speak to this, but something we already put in for, I'm hearing, are not available. They've been already bought up by other players on the market. And so that's been a frustrating experience for Hawaii and other jurisdictions, and something we're still working through. But I think the priority groups for the schools are going to be availability to test students, staff, anyone on campus who is symptomatic when they arrive to school. So at least at minimum trying to get supplies to all the schools to be able to do that piece would be ideal. And we just have to look at the numbers and what's able to come through procurement.
Okay, so, but going back to teachers, students, community members, who will have access to the tests?
So again, it will be determined in part by what supplies are available. We can sort of list out priorities, but then we have to look at what's feasible. So priorities, anyone who comes on campus sick, that's the top priority.
Okay, so it doesn't matter if it's a teacher or a student, if they're sick.
Right.
Okay,
They
that's
should
what I
get a
want,
test,
okay.
Yeah,
Custodian, if the,
exactly.
okay. If the principal, I guess it would be the principal or an administrator that determines, okay, whatever symptoms you have, you're gonna take the test.
Yes.
Okay. Senator Moriwaki.
Yes, this is maybe DOE. How many of your schools that are for next week's reopening are safe? I mean, that is, if you're leaving it up to the principals, do you have a checklist to say, okay, got this, social distance, got the whatever? Is there something that you have as criteria so that each of these school principals know what to do and whether I'm ready to open or not? Is there something like that, or somebody helping them?
Yes. So for the most part, the schools, Senator, are staying put with the same model that they used to close before fall break. And so let's start with that. And then I know that there have been, we have checklists, and we also have spot checks. Our superintendents, complex area superintendents have been monitoring and having the conversations with the schools around this. So those are in place. As stated in the board meeting last week, we are going to add some more monitoring systems in place to ensure that there's a level of not only compliance, which we expect already, but also of reporting. And sharing the information.
So we've got one report where a principal didn't know that they could just stay closed and do remote teaching. So it's understandable as you do your monitoring that if they're not ready and their campus is not ready, that they can continue with not reopening. Is that how they're being told the options are in terms of being safe when they open? Oh, she's not.
Sorry. I always do that. I forget whether I'm on mute or not. My apologies. So in that case, then it would be important to know because we have sent that information out and we've done communications. And so if there is a principal that is unsure, please reach out to that person, he or she, and ask them to either check with their complex area superintendent, or I'm always available. They have my text number, and they can ask for clarification. I do not want any principal to not feel confident in the decisions that they can make around their models.
The question I had asked the superintendent, how much of the schools, because she said she had distributed all the PPEs around the schools and they all have enough PPEs. To this point, even right now, I'm finding out that's not the case, and not all the schools got the proper amount of PPEs. So we have right now, in my district, certain schools have special needs kids that is on campus, smaller clusters than it used to be. But same thing what Senator De La Cruz said, is these schools that having these kids that is very vulnerable have the ability to have more than adequate testing and more than adequate PPEs. Because I am still yet getting the same amount of emails that I've been getting since the superintendent was here, said that every single school around the state got enough PPEs. And I asked her, can she give me a list maybe just start in my district. How much of the PPEs that she had supposedly distributed, and then she said she wasn't a distributing company, but I heard that she had the National Guard do the deliveries. So if she did have the deliveries, they have a manifest, right? Cabo High School, 8,000 masks. I mean, she would have that. So I like know, just with my district we start, how much PPEs that they had equipped the schools in prior and even to now of them consistently being open while they have these certain kids on campus. Our most highly, sickly, easily to get sick kids on campus. Because I'm getting, right now as I'm talking to you, over and over, they're saying the same thing, no enough PPEs for our special needs teachers, assistant aides, and for the students. So if we haven't had that then, when she said they delivered it,
No.
we don't know when.
But I thought, wait, Dr. Kimball, remember we had that discussion at the last hearing? Dr. Kimball?
I'm not sure what.
So
which-
remember when we talked about kids with special needs, especially when you're talking about droplets, and a lot, they may need help being fed. They may have behavioral issues where, there could be yelling or screaming, biting, and so those type of teachers would need additional PPE. And you said that.
Yeah, specifically face shields, yeah.
So, is that to the extent that you guys have determined?
Yes, so that's based off of the CDC recommendations, is to have at minimum face covering plus face shield if you may be dealing with kids that might be generating droplets.
So if I can also jump in, because I do feel like this is our responsibility in the Department of Education. And going back to Senator Favella's question, is that we do have a website for personal protective equipment distribution by school, and it is updated. So if you, it is on our website, and I will, if you want, I can send you the link, but you will see the PPE distribution by school, and you will also then see the special education specific PPE distribution. So when you ask me specifically about employees who are working with medically fragile or students who may require high touch for helping them to be in a learning environment, we know that they need more, and we have provided for them face masks, isolation gowns, gloves, and hand sanitizer that were delivered weeks ago, as I said before, through the help of Hawai'i. And so if there is, and our goal is a 60-day burn rate, and I will send you the link so that you can monitor that yourself, so that you know where each school is at in terms of what got distributed to the school.
Okay, like how you said you're gonna have somebody, Senator Sharon said, how you know that they have, and you're gonna have somebody go out there and check these things out. That's the number one thing you should check. First thing you should do right off the bat. I understand you got a website. Well, Senator Sharon was saying, principal's gonna tell you this and this, but then the teachers, you can send somebody out there to do an assessment. They're gonna tell you they don't want enough PPEs. This is the thing, what I'm saying is, so you're saying there's a website that the teacher and the principal can go to request more PPE? Okay.
Yes.
No, sometimes you're on and off. I'm not sure. Are you on? We
Now
cannot.
I am.
Yeah. Okay. Now
sorry.
we can.
Okay. So sorry. So yes, and there also is a 1-800 number that we have set up so that if anyone has questions about
Is it all different or
or
the same?
needs what is not they believe is available, that we do have a 1-800 number. So let me give you that information too, because again,
Then I
if
give
they
you
are
one time.
sharing their concerns with you, I also want to make sure that they are also aware of where they can communicate that, where there would be action.
Yeah, so if you can just, if you can give me the number and the link and email it to my office, and I'll share it with the community through
Yeah.
social media Thank
Right.
you.
And the person who will probably be emailing you, Senator, will be Bruce Ellerman and or Randy Tanaka.
Yeah, I know, Randy. Thank you. Appreciate that.
Okay, thank you.
Thank you.
Okay, I just have a couple questions from Senator Kidani, who was unable to make it because she has to take care of her daughter. Did Department of Health review and approve the DOE protocols for handling positive cases at schools?
Yes, those were reviewed a while back, I believe, by Dr. Park. And we continue to get questions and for clarification, and our school liaison is available for all those questions and follow-up.
Okay. What is the timeline for DOH to respond to a case reported by the DOE?
Our protocols, if we are the first to hear about a case, then our protocols are to notify the school principal within 24 hours. So if we learn that a case was on campus at a school while infectious, then the protocol would be to reach out to the school point of contact within 24 hours of learning of that. Obviously, we would do it sooner if that's the timeline that works. We're going to do it as soon as possible, but definitely within 24 hours.
Okay, is that for only students, or does that include teachers, custodians?
Any person who's identified as a case on a school campus that may have caused exposure there, that's the expectation.
Okay. What is the timeline for DOH to alert the DOE when a confirmed case is found to have had contact with a school?
I think that's what I'm hearing. I think that's the same thing we're just talking about. So if there's any confirmed case that had contact with the school, we would be reaching out to the school point of contact within 24 hours of learning of that contact.
Okay, the CDC recommends one or both of the first core measures of the community burden, in addition to a third core indicator, the self-assessed measure of school implementation of key mitigation strategies. Why has DOH only used one core indicator, and why is it not one of the recommended CDC indicators?
We're actually looking at including a second core indicator in the new version based on feedback from the school health committee as well. So that would probably be percent positivity, and this would also bring the plan into closer alignment with the discussions the state and the county had in developing the Honolulu City and County reopening metrics. So that's what will be presented to the school health committee on Wednesday, something with both measures in it.
Okay, what is the average response time of the DOE core team to reported infections within school? So I guess that would be the same within 24 hours?
24 hours.
And if DOH use the CDC indicators and threshold for cases of 100,000, how many of our schools could open next week?
I think based on the discussion we've had, that's going to depend on what we settle on for the new threshold. But again, one point I just think it's so important to make is the biggest determination of schools being ready to open next week is about what mitigation steps they're able to put in place in their classrooms. That is the most important part of the plan.
Okay. And when will DOE report school level data on infections?
So we do not have plans at this time to release school level data on infections.
Okay. Any other
Why?
questions?
Why?
There's a real balance in the information that gets shared out. Our goal as public health is to stop disease transmission, and there's different ways that we accomplish that. One is through learning from our past experiences, sharing the data on what's been seen so that we can show where problems were arising, how was disease transmission happening. That helps us learn and create policies to stop it from happening going forward. So that's the main purpose of data sharing. On the other side of it, how do we learn that? It's through collecting information from people, and it's often very personal information we're collecting from individuals. And we do that, we're able to do that because of our public health authority and because we're being entrusted with that information. And we're telling people we're not sharing this information except for purposes to stop disease transmission. So we take very seriously that responsibility as public health to release the minimum amount of information necessary to prevent further transmission of disease. And sometimes there's a desire to know more, to see more. I think we're all interested in the stories. We're trying to find ways to tell stories that are not going to identify people or lose the trust of the people who we need to talk to crack the outbreak, to stop the outbreak from happening. So we always want to be careful not to cross that boundary where people feel like, why would I talk to the health department, because they're going to turn around and say something that's going to identify me and cause stigma for me. So that's a very delicate line we walk right now, particularly in this outbreak, where we increasingly have people who don't want to pick up the phone, who don't want to talk to us, who don't want to tell us who their contacts are.
I guess I still, that's been the position from the beginning, and I understand what you're saying and the justification, but what doesn't seem clear to me, and maybe you guys have said it and I haven't understood it, is like how many, what exactly are you talking about? Like if you have a public school with 400 kids in it, and you have an outbreak of 22 individuals that have tested positive at that school, you clearly have a cluster there. I mean, is that sufficient enough? When the anonymity of these individuals is broken by as Senator Favela often brings up, by the information just getting out naturally from the public discourse or through the press, it seems like there's a certain point in any of these different scenarios, one individual positive or 15, where it does seem to me that there's some level of importance to have the state step in and say, yes, we're aware that there are positives here. We knew at this point, we engaged in our mitigation measures, and we're proceeding accordingly, right?
Yeah.
And so I'm just wondering where you folks, where's the trigger to engage in some proactive or even, just informative dialogue with the community so that it doesn't compromise your investigations, but also provides that level of clarity that's been a source of frustration for so long.
Right. A couple of responses to that. One is that once a school or any business or facility goes public, then we can verify, what we know about that situation. The point of clarity is always a difficult one, because when investigations are ongoing, the numbers are changing, and sometimes they even take numbers away. You investigate something and you realize that they were not part of that cluster, and you take that one away. It always causes a lot of confusion and upset if the numbers go down, right? So it can be difficult to arrive at clarity, but we do our best to share what knowledge is available at the time if we're asked to verify in that kind of situation. But in terms of proactively putting out information, it's going to be really different for schools of different sizes. And so, a small school, even releasing counts can be identifying in some cases. So it's something important to remember. And the other is that I think one other thing that's really important to explain is that public health, the role of public health is to be doing the fact finding so that we can prevent the disease transmission. And we do take that responsibility seriously. So if we aren't putting it on Facebook or we aren't putting it out in the news, it's not because we aren't worried about it or we aren't reacting to it. It's still going through the process of identifying the people who need to be notified, making sure those notifications have happened and the correct actions are being taken. So when you ask when would we put out more information, it's in situations where we realize that we are not able to reach the people who should be reached to prevent disease transmission. That's when we would make public in order to prevent further disease transmission. So if we aren't getting, answers back, if we know that we might have missed people, that would justify a press release to say this happened in this place, so we make sure everybody knows about it. But when we're able to trace the contacts in collaboration with the schools, they're able to provide us the information about who was in which classroom and who was on schedule on that day, then it is not, that doesn't meet that minimum necessary criteria to share it publicly in order to stop disease transmission, because we can do it without having to take that extra step.
So I guess what I want is I think you can't give me, and that's fine for me personally. But it may be something that's more in Phyllis's like realm of Kuleana, like Phyllis, to a certain degree, that's just not it's not acceptable to the public because we've had months of this situation in this manner, and people are still just as angry, if not more frustrated and confused and scared than they've ever been. And so I hesitate to say something got to change, because at the end of the day, I do agree that disease investigation has to be the number one priority. But I don't think this course of action as it relates to schools has been effective.
And I will say, I do think there are ways, we're committed to finding ways to share information that we can share, and get more of that information out.
But I think that's why I'm directing this more toward Phyllis, because I don't want to tell you that disease investigation should take a secondary role to alleviating the fears of the public in these individual communities. Because at the end of the day, we got to find the people who are sick, and we got to make sure that they get tested and they get treated. Right? That should be the number one priority. That's why I'm posing this to Phyllis, because in these individual school communities, we're just getting pounded by people who are not satisfied with the experience that they are undergoing in terms of communication and dialogue and the plan going forward with the schools. And I think that's what you're hearing here, right? And that's not necessarily your direct Kuleana, Dr. Campbell, but I think it is the DOE's.
So just to clarify, we do provide messaging response support to each school that is undergoing a COVID-related case, whether it's a potential or a confirmed case. And in the response, we not only are notifying the individual, but the potential close contacts in the school. And then we also then do a messaging to our school community. And so that's how we limit making sure that the people who might be exposed to and or hear or be involved in a case has that information. I think it's important to in a school community that they're aware of what's happening in their school. However, to put it out publicly across the state that a school or an individual school is dealing with that, it goes back to then what Dr. Kimball has said around what is the value of doing that. We do believe that it is important to share the information with those people that are most closely affected by the potential case. And as she said, we are putting out communication sometimes even before there's a confirmed case. So we are very careful about who we are communicating with, and we're keeping in mind the fact that we want to keep the people safe, and we want to make sure that they feel that they're getting the information they need to make that decision.
So again, the reason why I'm trying to be so careful in this dialogue is it's a somewhat impossible task, because you just can't get it right for every single different scenario. But I just think it has to remain a high priority, because that's why there's so much pressure on the reopening.
Yeah.
There wouldn't be otherwise, right? And that's all I wanted to say. I do appreciate the fact that you guys are struggling with this.
Yeah, and Senator, in every case in which we have dealt with COVID, a COVID-related case, we have communicated with the school community. But we first deal with the individuals that might be close to the case, because that is our first priority, and then we deal with the school community. And so I can give you that guarantee. We have a log, and we keep track of that to make sure that in every case we have done our part to keep the people who might be affected informed. without revealing the individual.
Phyllis, could I just ask, who is the school community? I mean, what is that the parents, or, I mean, who are they that you say you communicate to?
Right. So if the school is in session, then of course it's all of the employees and also the families that where their students attend the school.
So not all the parents or the PTSA or whatever, none of those groups.
PTSA are probably parent groups.
So they do get notified as well? Or?
Yes. Well, because they're parents, right? And it's
Parents of
a
all the
message.
kids, the parents of all the kids at school? I mean, how
Yes.
extensive is the community? School
Yes,
community?
and what you just said, our intention is to get to all the families. Because from the principal's point of view is that they feel very important, it's very important that they are keeping the trust of their school community. And so they are the ones that are making sure that their parents, we're helping them with their letters through templates. We're making sure that their voice is coming through on those letters. But we do lend support from the state level to them. And then we are helping them with communicating with their families. And that would include any of the PTSA or the school community council.
So they get letters, this is what's happening, something like that, the parents?
Yes, yes.
Okay, good. Thank you.
Okay, any other questions? If not, thank you guys for your time.
Thank you.
Thank you.